Hi learners, it's Em from Sononerds, and this video is on Unit 22, Quality and Performance. Unit 22, Quality and Performance. The quality of exams that are produced by an ultrasound department depend heavily on the machine being in proper working order and that the person using the ultrasound equipment is competent in all things sonography. To ensure both quality and performance, every department must have a quality assurance program in place and hold the sonographers to high industry standards. This is often done through lab accreditation. Section 22.1, Quality Assurance. To make sure the equipment is in good working order, a quality assurance program should be in place. A quality assurance program should occur at regularly scheduled intervals to ensure optimal performance of equipment. For most departments, this will occur every 6 months or every 12 months. In large healthcare settings, the biomed department will perform the tests and document the results. In smaller settings, the QA activities can be contracted out or may even be part of the sonographer job duties. Every sonographer is responsible for cleaning and inspecting the equipment prior to use on patients and should report any quality concerns immediately. As a sonographer, you should inspect the cords and the face of the transducer prior to using the equipment on a patient. Also pay attention to transducers that are not working properly, buttons and knobs that are kind of sticky, and other machine tools that have worsened with use. Cleaning filters and general upkeep of the machine is important as preventative measures that will help keep the machine operating appropriately as well. Only use cleaning agents that are approved by your infection control department and the manufacturer. The goals of a QA program are to ensure that image quality is optimal and to reduce downtime by detecting machine malfunctions earlier when they are easier to fix. They're also legally required. Due to the legalities surrounding QA programs, it'll be imperative that the documentation is accurate and organized. By implementing a QA program, the department will be able to confidently image patients and reduce the number of repeat exams as well. The periodic QA program should assess system components. This will be looking at all of the transducers, using phantoms and test objects for accuracy tests, and running diagnostic computer programs on the actual computer system itself. The program will also require the performance of repairs. If anything is broken or needs to be replaced, such as transducers or knobs or buttons on the machine. One of the first things that goes out on the machine that is noticeable to sonographers is the locking mechanism on the monitor. If you're practicing good ergonomics and lifting that monitor to eye level, you'll notice sometimes they kind of sink down. The QA program performer should also do preventative maintenance. Now, as sonographers, we should be cleaning and doing a lot of that on the day-to-day, but the QA person can also clean the keyboard, clean the filters again, and calibrate touch screens that may be on the system. And lastly, everything needs to be recorded. It's very, very important that organized and accurate records be kept of all QA activities. Labs that seek accreditation can find more QA standards through the accrediting agencies. I do have a couple links in your workbook that you can check out about news stories related to hospital systems not maintaining their equipment and lawsuits that have ensued. One of them is a link to an article that talks about a machine had not had any QA done on it for about 10 years. It was greatly out of date. The operator was a physician who had not used the equipment very often and had essentially decided that a pregnancy was no longer viable, and they put off giving birth to this baby. The sonographer was on call, eventually makes it in, brings up the department ultrasound equipment, and indeed says no, there is life, and the baby is delivered. Baby ends up having brain damage due to the delay in delivery, due to the poor equipment that the physician was using. And then the other link is to an article that talks about a hospital system failing to keep records of how they cleaned their ultrasound equipment and how that led to the possible contamination and infection of patients. And again, just really shows us why we do need to be vigilant on our record keeping and performing our quality assurance. Here's an example of a few of the things that you'll definitely want to look for as a sonographer before every single patient. Make sure that your ultrasound equipment is in good operating order. For example, on the top here, we have a cracked case. This is very dangerous to the patient. That cracked case can mean that some of the electrical energy can get out, and we could possibly be shocking the patient. Same idea here. We have the matching layer of the transducer has little holes in it. This can be very dangerous. Again, electrical energy can get out. We can start to ruin the elements that are just below this layer. Be very careful of your cords. If you run them over, you are damaging the wires that are in there. Remember, the wires connect the elements back to machine electronics. And if those wires aren't working, then we're not getting the information back. And then again, just some issues with the cable itself. So make sure to inspect all of your equipment so that it is in proper working order. If you find anything that needs attention, take it out of service, call the biomed or your quality control or the manufacturer, whoever you've contracted through, and get that equipment fixed for patient safety. Section 22.2, Performance Testing. Now, part of the quality assurance program is to do performance testing. When a sonographer notices that a machine is imaging too dark or that the images may be a little blurry, this is a subjective test. It's the opinion of the sonographer, and another user might not notice the same things. Performance testing in a QA program is done as an objective test. The machine tools are used under the same settings, and the results are repeatable. This is an unbiased factual representation of the machine performance. So be familiar with subjective is opinion, where objective is facts. So to perform objective tests, we are going to use phantoms and test objects. Now, the phantoms and test objects are used for every periodic QA event to minimize outside factors affecting machine performance. So we're going to keep all the system parameters like which transducer we're using, the gain, the focus, compression, and all the other tools all at the same setting. It's going to be very important to the objectivity of the test. Even room lighting and monitor settings should be the same. There are phantoms that we can use for both 2D imaging and Doppler imaging testing. When performing 2D testing, the operator will test 5 parameters of the system. First being detail resolution. Now, detail resolution is going to include axial resolution, lateral resolution, and elevational resolution. These tests are performed by observing the distance at which point spread artifact occurs in a tissue phantom or in a pin object, and observing the size of the beam with a slice thickness phantom. Another parameter evaluated is the contrast resolution. Contrast resolution will look at the machine's ability to display varying grays accurately, and this test is usually done with a tissue phantom. The penetration or the sensitivity of the machine will be tested, also through a tissue phantom, and this is going to be looking to see if the machine can detect weak echoes at all depths. Range accuracy is going to use a pin test object or a tissue phantom, and range accuracy is going to prove that the machine can detect accurate size and spacing at depth of reflectors in the vertical plane. Registration accuracy in general is also going to look at horizontal reflectors and the accuracy of pins in the very near field known as the dead zone. Lastly, measurement accuracy will be evaluated. This again is typically done with a tissue phantom. Calipers are going to be replaced on reflectors imaged in the phantom and then compared to the known value of the reflectors. Now, you may have noticed that I said quite often when talking about the 2D imaging parameters that they're tested via a tissue phantom. So tissue phantoms are going to mimic soft tissue, and the biggest way they do that is through matching the propagation speed of 1540 meters per second. The tissue equivalent phantoms are going to attenuate just like soft tissue does. They're made of aqueous gel and graphite particles to mimic that soft tissue. And then they're going to contain metal or nylon pins for performing those accuracy calibrations. And they're also going to contain solid and cystic masses that mimic structures. Now, the soft tissue phantom has multiple windows to image through, and depending on the window, the user is testing different parameters of the machine with the phantom. The soft tissue phantom contains a map of the reflectors found within. And by using this map for comparison, the QA tester can determine if the machine is accurately representing the quote-unquote anatomy in the phantom. So as a sonographer, you really should understand what is being tested with each set of the reflectors found on the map. So let's take a look at some examples here. This is the ATS 530 multi-purpose phantom. This is a soft tissue equivalent phantom. Remember, it's going to have a propagation speed of 1540 meters per second, so it attenuates sound similarly to the body. Notice here that we have multiple scanning windows. We have one on the top and we have one on the side. On the back side of the phantom will be the map, and it'll look something like this. It'll tell us how many pins can be registered in the dead zone, how many pins are in this horizontal group here, how many pins are in the horizontal group here, how many pins are in the vertical group. We have our axial and lateral resolution testing pins here. We can see anechoic target structures. So on imaging, these will all be anechoic. The biggest one should measure 8 and then 6, 4, 3, and 2 millimeters. And then we have our contrast resolution on the side here. So this map tells the tester what exactly is in the phantom, and then you compare this map to what you're seeing in your image. Here's another type of phantom. This one is testing measurement accuracy in the 2D and 3D applications, and the 3D wire test object is going to test for registration accuracy in both the vertical and horizontal fields. So here's an example of the map that we would see with the 3D, 2D calibration. This is going to be for measurements. So there are egg-shaped structures. The tester would measure these structures and see how well the ultrasound machine does compared to what is known to be in the phantom. Here's an example of the registration. Again, we have group 4 being the dead zone registration, group 1, 2, and 3 being our horizontal registration, group 5 being the vertical registration, and then we have group 6, which is kind of a combination of the two. We can see a little bit more about slice thickness with that one. And you can see on the top picture here what those pins look like then in ultrasound. So each of these pins should match up with what's on the map. They should be the same distance apart. They should all be visible. And you can tell kind of where these ones that are right next to the focus here, these ones are a little bit smaller compared to the ones in the far field where we're seeing a lot of point spread artifact. Here's another example of a soft tissue model. Again, 1540 meters per second. The intention is to attenuate sound just like the body would. On the back side, again, we can see the map. This one happens to also include elasticity markers. So if you have elastography on your machine, the user could test that to make sure that they are getting accurate measurements back from their elastography tools. And so here's an example of an image that is produced by that phantom. So again, we have our dead zone up at the top here. We have our vertical or our range accuracy. We have our horizontal calibration. We have cis going down the side here that are measurable. We also have our contrast resolution in the far field. We have a couple areas of axial and lateral resolution. Again, those are those kind of curvy lines that go by. Those are testing the axial and lateral resolution. So here's a close-up of the map. We can see all of those items listed. Quite often on the map, it says exactly what they're testing for. So horizontal distance, we should be able to see 1, 2, 3, 4, 5, 6 pins, probably all about a centimeter apart. Same idea here, we should be able to see all of these pins, all a centimeter apart. If our contrast resolution is appropriate, we should be able to see all of the different grays, and we should be able to see clear anechoic structures matching up with these cylinders as well. If we're starting to see some kind of echoes in there, then we can kind of evaluate the elevational thickness or the grading lobe artifact as well through that area. So just to talk a little bit more about what we can see on the map and how that affects what we're looking for, let's take a little bit closer look. So the first one is the dead zone. Now the dead zone is going to determine how accurate the machine is, typically in the first centimeter of the image. So you can count the pins on the map and then match it to the image. So we have 1, 2, 3, 4, 5 pins in that first centimeter. By counting the pins, then we know how much we're actually missing from this near field. Maybe you can only see 3 or 2 pins in this area, then you know you're missing about 2/5 of a centimeter. Again, axial and lateral resolution are determined by these lines that are curving here. Just coming from the top will test both axial and lateral resolution because we do have this little bit that curves up. So not all of the models are going to have both a horizontal line and a curved line. At the very least, they should have that curved line. And again, we can see that at different depths here. We know that axial resolution should remain the same through the depth of the image, but we do know that lateral resolution changes based on the beam. Basically, what we're looking for is where these pins start to merge together. Once we no longer have independent pins, then we know that we've met our threshold for the axial and lateral resolution. Registration accuracy in general is just going to be, do we have the right pins and the right distance apart in the horizontal and vertical planes? So registration accuracy in general does refer to both planes. Here we are seeing the horizontal version of it. So we have horizontal further into the phantom, a little bit further apart, compared to our near field ones that are a little bit closer together. Range accuracy does only refer to the vertical plane. So again, registration accuracy can be horizontal or vertical, but if we just call it range accuracy, that is the distance or depth into the image. So range accuracy is going to determine if the machine can accurately place all of these little reflectors into the depth of the image. We expect them to be a certain distance apart and to be all displayed. So the user can use calipers to measure to make sure that they are displayed correctly in the appropriate distance from one another, and then count them to make sure that they're all present. Contrast resolution, again, is how well the machine can differentiate between grays. So this phantom allows us to test at different depths. Can we get different grays at both levels? And then lastly, we can do measurements on the items that are found within the phantom as well. We want to know how accurate the machine is at measuring structures, and you'll notice that we have them at different depths, because we want to know that our near field measurements are just as accurate as our far field measurements. Another interesting thing as well, depending on where your focus is set, some of these smaller anechoic structures might not be visible due to the lateral resolution of the equipment. I just want to highlight again, testing for the dead zone is going to look at the pins that are very, very close to the near field. It's about as shallow as you can get into the near field. And it's usually the first centimeter of the image. So it's going to allow the tester to see at what point the machine begins to register the real reflectors. And there are 9 reflectors that are supposed to be in this phantom. But when I use my ultrasound machine with the phantom, I only am able to see 5. And there might be a couple more in here, but there definitely is not going to be 9 visible through here. So what we end up seeing is that we're losing maybe about a third of our first centimeter before we're actually seeing any reflectors. So what do we do then if we have structures that are in this first third or like right in the skin line? Well, there's something called a standoff pad or a gel pad. And these gel pads are going to allow for the dead zone to basically be lifted off of the skin line, and then the true structures are going to start to be registered. So the gel pad or the standoff pad comes in multiple forms. The idea behind them is that they do not cause any attenuation. So you would just place this right on the patient's skin with a little bit of gel underneath it, a little bit of gel on top of it, and then you place the transducer right on top of it. So this is a little bit larger one for a bigger area. They have smaller ones. They have ones that hook around the transducer face. Not all labs have this though. So I've done this quite often. Have filled a glove with water, and then I've used that to scan as a standoff pad. You can also just use a giant glob of gel if you need to and kind of float in the gel, or even put the hand in a bath of water, and then you can scan through the water. If you just put the transducer into the water, you can scan down to the surface of the skin. And this is a really good example of the change that it makes. So this is scanning directly onto the skin. We have a very superficial structure, most likely a sebaceous cyst, and the structure is not as well evaluated because we are right to it. We're right at the skin line. We're losing a little bit of that information. In picture B here, we have implemented a standoff pad. So now we have all this space in between. We can evaluate the true skin line, and then we can evaluate that cyst as well. And what we end up seeing is there's a little track here, which helps to diagnose this image. I mentioned then too that axial and lateral resolution are very important concepts to understand when we're looking at our QA phantoms. And again, those are going to be tested through these lines that kind of curve up. Now, one of the examples I showed you also had a little horizontal line that came across here. This one does not. So more often than not, you're going to see kind of this curvy line representing the axial and lateral resolution testing point. Basically, what we are doing is trying to determine at what point do we start losing these individual pins. So you can see here we have 1, 2, 3, 4 reflectors, which match up with 1, 2, 3, and 4. After that, we kind of start to lose a little bit of information in here. It's hard to tell, especially since this is a picture of a picture, but we can tell that things are starting to spread out here. It's just not as accurate. Same idea here. We have 1, 2, 3, and then we kind of start to lose it again. So 1, 2, 3. So we're really losing this information in here. So this transducer, most likely with the way that it's set up, is going to have poor axial and lateral resolution, especially for reflectors that are this distance apart. So it's kind of interesting to see all those formulas that we talked about with axial and lateral resolution kind of come to life. How the machine can interpret these reflectors as one, even though they're actually two. Another type of phantom that I mentioned when we were talking about the different parameters that the QA tester will be using is the slice thickness phantom. And the slice thickness phantom is going to be used to evaluate the elevational plane and the beam profile. So the slice thickness phantom also has multiple scan windows to better assess the beam profile, and it's made of a tissue equivalent gel and an echogenic band. So basically what the tester will do is place the transducer up here on the 45-degree scan plane. Now in theory, the beam is going to come down, interact with the echogenic band, and we should just see a nice thin band going across our picture because we expect the elevational plane to be very thin. The height of that band actually gives us a better idea of how thick the sound beam is at that area. The other window that we want to use then is the 90-degree scan plane. We're going to be 90 degrees to the band, and what we end up seeing with that is a very specific scattering of the echogenic band that kind of gives us an idea of the beam's shape, and so we can actually see the lateral resolution in the image. So here's a couple examples. This first one is that 45-degree window. So the slice thickness is actually this brighter white band here, and we're still even getting a little bit more artifact beyond it. So that gives you an idea of how thick the beam actually is. This is using the 90-degree scan plane. This is the near field coming down to the focal point, and then you can see how the beam diverges in the far field. So again, we can physically see the beam narrowing and then diverging, just like we've talked about with all of our formulas and how the beam interacts with reflectors. The pin test object is not as commonly used anymore now that a lot of the tissue phantoms also have pins within them, but the standard one is called the AIUM 100mm test object. And it is a clear case that you would fill with water, and then there are stainless steel pins in it that can be used to assess for registration accuracy. So again, the equipment would be filled with water, which doesn't attenuate sound at all, so it doesn't mimic soft tissue, but it does allow us then to see all of these pins that are in here, and we can then test the dead zone, the vertical, horizontal registration accuracy. Now there are other soft tissue models available for scanning that are useful in teaching the basics of ultrasound when a real patient is not available. These models use tissue mimicking substances to attenuate sound just the same way and provide a semi-realistic scanning experience. So many of these models are going to be very helpful for practicing not only imaging structures, but also practicing image-guided needle procedures like biopsies. And then even more recently, simulation computer programs are being utilized to teach ultrasound. Sensors in a model transducer are used to recognize the user's motions, and those are then reflected visually into the program. And then some of the simulator companies come with a tissue model, and some companies even use virtual reality to simulate the scanning experience. So here in this image we have a couple examples. This is a fetal model. We can see the fetus is in here. I believe you can rotate it around and make the baby breech or transverse or kind of flip the baby into different positions. This is one where a fetus is within the belly as well, where you can kind of get the experience of scanning on a pregnant person's abdomen with the rounding of the fetus. Here's an example of what a picture looks like from these models. No, they're not perfect, but we can get the idea of where we would do like an abdominal circumference, where we would do head circumference, those kind of images. On the bottom here, we have a breast model where a person is practicing their needle procedure, so they can practice holding the transducer on a breast and then have a target for inserting that needle into. Now this video is found on YouTube. The full thing is linked in the workbook, but we're just going to jump to a different part of it. This is an example of virtual reality. There is no sound for this part. I'll just talk a little bit through it. Right now, they are looking at the chest that's in front of them in the virtual reality room. And as they scan across ribs, that's where we're seeing kind of the cutouts. You can see the chest on there when they look there. And as they turn the transducer, they get different views. They have other things that they can do in this room. This is actually set up as a surgery simulation, but it also uses echo to teach a little bit more about how the heart is set up as well. And then I have another clip that I linked to in your workbook of a different company that you can check out. This one is a TEE and a TTE simulator. So not only does it show you like 3D models of the heart and how to image and Doppler these structures, you can then practice on a soft tissue phantom using a special transducer that kind of shows you what you're doing in the TTE, or you can place a TEE transducer and kind of get some more practice with that. So this first little clip is the TEE probe being behind the heart in the esophagus, and you get to see kind of a simulation of what it would look like. And again, this is just a very safe way to practice these different modalities before you're actually performing them on a patient. So you can check out both of those videos in full using the links that are in the workbook. Section 22.3, Doppler phantoms. Doppler phantoms are used to assess different parameters of Doppler ultrasound, such as penetration and sensitivity again. So that's how well the machine can detect pulse wave, spectral, continuous wave spectral, and color Doppler at different depths. Range accuracy allows the tester to understand how accurate the machine is in placing the sample gate and detecting flow direction accurately at different locations. We also have peak velocity accuracy, which is where we want to know, can the machine accurately measure the peak velocities as they are going by. And then we also have the opportunity to test for spectral broadening and lateral resolution. And because this is a QA program, we want something that is repeatable and testable every single time that we're testing these parameters. So there are Doppler phantoms that allow for that. So it ends up being a little bit trickier to do because now we have to implement some sort of moving object that moves consistently so we can always test the transducers and the machine tools at the same settings. So what we have found as far as Doppler instrumentation phantoms go is that we have 3 different ways that these can be created. We can create a vibrating string model, a moving belt model, and a Doppler flow or pump model. So here's an example of a vibrating string model. What we are seeing here is a transducer holder. So the transducer would be holding this. There would be water in this basin here, and then we would turn the motors on, and these strings would start to vibrate. And the vibration of the strings would cause motion that would be detected by the ultrasound equipment, and then we'd be able to see that in our spectral tracing. So here you can see where the string is, and we can see the pulse wave line coming down with the gate placed directly over the string. And then again, we just have steady flow, or what's mimicking steady flow, and so we can see that in the window here. The moving belt model would actually look very similar. I believe that the belt is just a little bit thicker, and we have just a few more gears that are kind of rotating the belt through in a very similar fashion. The pump model then would look something like this. We have basically a soft tissue mimicking model, and then through the middle of it is a vessel. We have little knobs on either side that the pump can be hooked up to. So a pump is needed for this. You would take your pump and attach one side to one and the blue side to the other. So you have a method for the fluid to flow through the vessel out to the pump and then continue that cycle through. You can set the Doppler flow pump to different velocities. The velocities then would be known by the pump, and then you could go into your equipment and test. Did we accurately measure velocities through there? So the pump method uses fluid that is very similar to blood, uses a phantom that mimics soft tissue with a vessel running through it. Section 22.4, Transducer Element Integrity Tests. Each transducer should be tested to make sure that the elements are working too. So in the sequential transducers, it's actually a little more obvious when a crystal is broken due to the dropout that occurs in the image. But we know it's not as obvious in phased arrays or when only 1 or 2 crystals are damaged. So each element in the transducer can be tested directly through an integrity test. This is going to use a water bath and then some other mechanicals. The report will determine which elements are working as expected and which are needing replacement. If enough elements are broken, then the whole transducer face needs replacing. So here's an example of the holder for the transducers. There would be a bath of water in here. The transducer would be held up here, and then the face of the transducer would be inserted into the water. The machine then would use the other electronics receiving the sound beam to understand how the elements are working. So here we can see a linear transducer, in the holder a curvilinear, and the transvaginal. Whatever the equipment is should be able to fit into your element tester. And then the report ends up looking something like this. So on top here, we can see that we're using a phased array transducer. We have our sector image shape, and we can see here that we have element 1 all the way over to probably element 100. So this phased array transducer most likely has about 100 elements. We then have different levels of sensitivity, green and above being good. We want sensitive elements. Yellow being okay, and then what we're worried about is that if we have too many that drop below that red line, means that they're not working very well. So the sensitivity is tested, and we can see that this transducer is in fairly good working order. All of the elements are sensitive enough to meet the at least okay threshold. And we can see that in our picture then. We have a very nice image of the anatomy. Compare that then to a phased array transducer that isn't working as well. Again, we don't get the same dropout that we would expect with a linear sequential or a convex sequential. We just get kind of erratic steering, erratic imaging from a phased array. And we can kind of see that here. We're starting to get very fuzzy, kind of blurry imaging. We've got a lot more shadowing coming off of things. We're just not getting the same highly accurate, highly detailed image like we were on the top picture. And that is because we've got a giant group of crystals that are not doing well. So again, they're all working together to make this image, and it's got probably almost half of the crystals that aren't working. So all of these elements would either need to be replaced or just replacing the transducer in general. Section 22.5, Accreditation and Credentialing. So sonography labs can be accredited through 3 main accrediting agencies in the United States. We have the American College of Radiology, or ACR, the American Institute of Ultrasound and Medicine, or AIUM, and then the Intersocietal Accreditation Commission, IAC. ACR and AIUM are more likely to focus on the general departments, where IAC is more focused on echocardiography and vascular ultrasound. Now, being awarded accreditation means that the sonography lab and its sonographers adhere to the best practices put forth by these agencies. Accreditation is maintained by submitting cases and quality assurance data and other resources to show compliance. Oftentimes, part of the accreditation process is to have credentialed sonographers. And when your lab does get accredited, it is something to celebrate. It's not necessarily difficult to get accredited, but there's a lot of work and organization that goes into presenting a complete case study for these accrediting bodies to award accreditation. So, speaking of credentialing, sonographers and interpreting physicians can seek personal credentials, typically through 3 main accrediting agencies as well. Now, personal credentials are not legally required everywhere, but they are often used as a metric for qualified sonographers. The 3 main agencies are the American Registry for Diagnostic Medical Sonography, or ARDMS, the American Registry of Radiological Technologies, ARRT, and then Cardiovascular Credential International, or CCI. Now, each of these credentialing bodies also kind of focus on different areas. The ARDMS is probably the biggest one that most people seek their credentials through in the United States. The ARDMS starts with an SBI, which is the goal at the end of this physics program, to take your SBI, your sonographic principles and instrumentation test, and then you can go on to take any of your specialty boards. That would include adult or pediatric echocardiography. You can do abdominal, MSK, obstetric and gynecology, pediatrics, breast, and then you can do vascular. There's just lots of options through the ARDMS to become credentialed. Many sonographers actually hold more than one credential. The ARRT is a little bit more geared towards radiology, like X-ray, CT, MRI, that kind of stuff, but they do have some ultrasound credentialing in there as well. Through the ART, they typically offer a vascular ultrasound credential, a general sonography credential, and a breast sonography credential. Lastly then, CCI is a little bit more focused towards the cardiovascular side of things, so they provide credentialing in echocardiography and vascular technologies. Section 22.6, Quality Assurance Statistics. Now, part of being an accredited lab is providing statistics about the quality of exams being performed. You should be able to correlate the ultrasound findings to other modalities. So let's take a really high-level look at what quality assurance statistics are, as it is an area of knowledge outlined by the SPI, but not an area that will be heavily tested. Let's go ahead and start with some definitions first. The first one is gold standard test, and this is going to indicate the best test for a certain disease or pathology. For example, CT is the gold standard for evaluating for appendicitis. Now, ultrasound's actually pretty good at it too, it's just not as sensitive or specific as CT. Ideally, our gold standard tests are going to have a sensitivity and specificity of 100%. So what does it mean to have 100%? Well, in sensitivity, which is also known as the true positive rate, this is the ability of a test to correctly identify all patients with disease. So our gold standard test is 100% able to determine which patients actually have a disease. Specificity is the true negative rate, and that's going to measure the proportion of actual negatives that are correctly identified as such. So for example, it's the percentage of healthy people who are correctly identified as not having the condition. So again, if we have a 100% specificity, then the test is able to 100% of the time know which people do not have a certain disease. The positive predictive value is the probability that a subject with the positive screening actually does have the disease. So if you have a CT and they say you have a positive appendicitis, the positive predictive value is how sure can you be that that is true. Where the negative predictive value is the probability that subjects with a negative screening test really don't have the disease. Using the same example, if we have a CT and it's read out as a negative for appendicitis, how confident are we that we are actually negative? That's the negative predictive value. Prevalence then is the proportion of individuals in a population having a disease or characteristic. So prevalence is the statistical concept referring to the number of cases of a disease that are present in a particular population at a given time. So the prevalence is just how many people have appendicitis at a certain period. One of the theories is that allergies causes appendicitis to increase, so the prevalence might actually be higher in the spring for appendicitis. The accuracy of the test then is how good a test is overall. Is it capable of finding positive and negative results? And then the reliability of the test tells us how consistent the test is. Does the test consistently provide those accurate results? So knowing kind of those few QA statistic definitions, we can look a little bit closer at how they're all related to one another. The biggest thing that we want to keep in mind is that when we are looking at a test, we want to know how a test does when compared to the gold standard. So if the CT is the gold standard for appendicitis, then we're taking our new test or our comparison test and comparing it to the CT. So we're going to compare ultrasound to CT. How good is it at doing that? And when we do that comparison, there's a few things that we need to keep in mind as well. First, the gold standard is perfect. That's what we need to assume. Even if it really isn't, we're assuming gold standard is perfect at detecting disease. If the comparison test says something is true, then that means that it matches what the gold standard would have found. And if we look at the comparison test results and say they're false, that means it doesn't match with the gold standard finding. We'll go over each of these boxes in a little bit more detail, but in general, I want to show you kind of the best way to look at this instead of trying to memorize all of this. Now we're going to do columns first, and the columns have to do with the gold standard. The gold standard would say that all the patients in this column have disease, so they're positive for appendicitis. All the patients in this column do not have the disease, or they're negative for appendicitis. So again, the gold standard CT will say those patients have appendicitis, the other patients in the right column do not have appendicitis. Now, if we look at the comparison test, so we're coming from the comparison test side, patients in the top row will have tested positive for appendicitis, where patients in the bottom row have tested negative for appendicitis based on the ultrasound, or whatever your comparison test is. So this is where we get then our true positive, false negative, and true negative. Let's start in the top corner here looking at the true positive. Remember, gold standard test said that the patient has the disease. Comparison test said that they do as well. These results are correct. The comparison test is positive. Gold standard test tells us that the patient has the disease. Everything matches. The higher this number is, the better the comparison test is. Let's look at false positives then. This patient does not have the disease, according to our gold standard, but they tested positive with our comparison test. So what we end up seeing is that these results are incorrect. If they're incorrect, they are false compared to the gold standard. The comparison test said they were positive, but the gold standard test says that they do not have disease. These do not match. Let's jump down then to false negative. Again, gold standard test says that the patient has disease. They are positive for appendicitis, but the comparison test says they don't have the disease. So these results are also incorrect. The comparison test is negative, but the patient has disease. It's a false negative. So again, these do not match. And then our true negative test, the results again are considered correct. That is because our gold standard says that the patient does not have disease, and our comparison test also said that the test is negative, and these all match. So what we are looking at when we are looking at this four-square is that we should have a lot of true negatives. Most people don't have disease. We expect tons of true negatives. We want our true positives to also be high. We want them to correlate with one another, our comparison test and our gold standard test. Ideally, we have 0 false positives or 0 false negatives. That's ideally, but we will find that we do have some false positives and some false negatives. Depending on the values that fit into these 4 categories, we can then take a closer look at all of the sensitivity, specificity, accuracy, positive predictive value, and negative predictive value with our formulas. So for example, our sensitivity is equal to the true positive value divided by the true positive plus the false negative multiplied by 100%, because most of these are presented as percentages. Now this page here, I'm not going to go into any more than this. If you're interested in learning more about it, there's tons of videos on YouTube, but this is not going to be on the test. I would focus most of your energy on the definitions, especially that gold standard test is the best test for a disease, and then sensitivity and specificity are how good are they at predicting true positives and how good are they at predicting true negatives. But again, in the workbook, you can check out the example that I gave you, again, showing true positive, false negative, true negative values, and then calculating all of the QA statistics. And that, you guys, is it for quality assurance. So again, remember, quality assurance must be done periodically. It's regularly scheduled. You have to have a QA program legally. You're going to be testing the parameters of the machine. The goal is to test them in objective standards. So you are using phantoms and models to produce the same results every time. If you are not getting the same results, then you can objectively say that the machine is worsening and something needs repaired. As a sonographer, you are responsible for making sure that you are checking those cords, checking those transducers, checking your equipment, that it is safe to use on patients. If it is not, immediately call somebody, report the quality assurance issue, and then take that product out of service so you don't use it and jeopardize a patient's safety. You should know the 3 types of models that are used in 2D imaging parameters, and then you should also know the 3 types of models for the Doppler models as well. As far as the QA statistics go, mostly focus on what the definitions are, specifically the gold standard test, the sensitivity of a test, and the specificity of the test. Again, you have a couple of activities in your workbook and the open-ended nerd check questions that you can go through to double check your knowledge of the material presented.